Okay, thank you. I'd like to thank the organizer for inviting me, and I will present the final result of the CyberNeo protocol, which is a neoadjuvant concomitant CyberKnife chemotherapy for breast tumor. So it's a phase 1 study of escalating dose with the CyberKnife. So as you know, the breast cancer is one of the most lethal female cancer. Neoadjuvant treatment is done now if tumor is more than 3 centimeters or if the tumor-breast ratio do not allow a conservative treatment. You know that prospective studies have shown that there is a real advantage to do the chemotherapy, but there is no advantage between the neoadjuvant treatment or the adjuvant treatment. But we know that histologic complete response is a major prognostic factor. We know that neoadjuvant treatment should include anthracycline and taxane, and with the new protocol, a complete histologic response can be expected as 15 to 20%. Of course, after this treatment, we need to do surgery and conventional radiotherapy. We initially think to include in this protocol 10 to 15 patients a year, and the idea was to help to increase the histologic complete response. So for this protocol, we use the CyberKnife, as Professor Gérard explained. You have here a small LINAC, here the robotic coach, and here you can detect the position of the tumor, and the CyberKnife is moving with the breathing of the patient. Of course, you need to implant near the tumor some fiducial, as you can see here. It's gold fiducial that you need to input in before the treatment. And with this fiducial, the CyberKnife is able to track the tumor during the breathing with very small margin. So, this is to explain the difference between the conventional neoadjuvant treatment and the CyberKnife, the CyberNeo protocol. As you can see here, you have 3 cure of docetaxel, 3 cure of FEC, then surgery, then radiotherapy, then a boost. With this protocol, we start the 3 cure of docetaxel, we invert. Normally we do the FEC in first, but for this protocol, as we don't want to have a kind of recall reaction, we inverse, we do docetaxel first, then 3 cure of FEC, then surgery, then radiotherapy, and we remove the boost, and we do the boost with the CyberKnife during the second cure of docetaxel. Inclusion criteria was of course, non-conservative treatment of breast cancer, unifocal breast cancer, fiducial with gold clips need to be in place, histology must be proven, and of course, standard neoadjuvant chemotherapy must be allowed. Exclusion criteria was, of course, if surgery was not allowed or if chemotherapy was not allowed. What are the objectives? The main objective was to evaluate the tolerance of the concomitants of the CyberKnife with neoadjuvant chemotherapy. It's a phase 1 protocol, so it's an escalating dose protocol. Minor objective was to assess the result of radiochemotherapy on the number of sterilized histological exams, the quality of the surgical resection on the complication after the surgical resection, on the quality of light. I don't speak about MRI response. How to assess the tolerance of the main objective. First, we do a dermatological evaluation. It is made by 2 different dermatologists in another hospital. That is the clinical evaluation. Then we had instrumental evaluation with a chronometer, with a dermoscope, and with an ultrasound exam. Pathology examination is made in accordance to the Satelov classification. It's very simple. TA it's when you have a complete response on the tumor. TB, it's when you have more than 50% of response on the tumor. TC is when you have less than 50% of response on the tumor. And TD is when you have no therapeutic effect on the tumor. And the same for the node NE, NA, NB, NC, and D. Surgery was made by 3 different surgeons, and we have recorded all the possible complications, and we want to know what think the surgeon of their resection before they do it. And of course, we are very interested of the quality of life. So this is a flow chart of this protocol. First examination here with a complete dermatologic evaluation. First cure of docetaxel. Second cure of docetaxel with a CyberKnife. Then a new complete dermatological evaluation. Third cure of docetaxel with, again, a complete dermatologic evaluation. The 3 cure of FEC. Then the last complete dermatologic evaluation. Then we ask to the surgeon how they will perceive the quality of the surgery, how they do the surgery, and the complication of the surgery. How do we do the contouring for the breast tumor? We use a CT scan with the thicknesses of 1 millimeter. We do the contouring of the GTV on this CT scan. We were helped by an MRI, but we have not automatic matching with MRI. Most of the case, we use the help of a radiologist. We had a margin of 5 millimeter to the GTV in order to get the CTV, or less, if, for example, we are in contact with the skin because the skin was defined as an organ at risk. And the chest wall was again defined as an organ at risk. So you can see here the skin, organ at risk, chest wall, organ at risk, GTV, CTV, and the CTV is reduced here because of the vicinity of the chest wall. And you can see here kind of dosimetry with all the isodose. The dose escalation study, we start at level 1, 6.5 gray, 3 fractions, so a total of 19.5 gray. And we go on 1 gray by 1 gray up to 10.5 gray, 3 fractions, so a total dose of 31.5 gray. Remember, keep in mind that after this treatment, you will have surgery that removes the tumor, and then you will have a complete radiotherapy without the BOST. So this is an example of the treatment. You see here the skin, chest wall, the CTV, GTV, isodose, and you see here the 4 fiducial surrounding the tumor, so the CyberKnife can follow the movement of the tumor during the breathing. Patient characteristics. We started this study in 2007, ended in 2010, December 2010. We include 25 patients, median age 47 years. We have 18 T2, 7 T3, 15 N0, 10 N1. Of course, no metastasis. And we have a follow-up up to 5 years. And you see the inclusion are very regular in this protocol. So, what are the skin toxicity in this in this 25 patients? We had 2 grade 2 toxicity at level 1 and 2. We had 1 grade 1 toxicity at level 3 and 1 grade 3 toxicity at the last level. We will see now the different toxicity. Surprisingly, it was an axillary toxicity at distance from the treatment we made by the CyberKnife. And you see there is a real, this is the time, and this is the first examination, docetaxel with the CyberKnife, and we have immediately after the treatment, we have an axillary toxicity, staying for more than 1 month and completely disappearing at the third evaluation. So we try to understand what's happened. And as you can see, we have this toxicity here, skin toxicity, and we do the treatment here. You see the toxicity is here, and the tumor is here, and the isodose are here. So we have less than 10% of the dose here in the axillary node. So what we made, we think of a kind of a bolus effect or something like that. So what we do, we change the patient arm position. I have a friend in Italy who tried to do the same to do a treatment of the breast tumor, and he had the same axillary toxicity. So he does the same as us. He just change the patient arm position, and we do a real-time axillary dose monitoring with a thermoluminescent diode dosimetry. The third toxicity was a recall reaction. Unfortunately, we invert the sequence of the chemotherapy. We do 3 FEC with no toxicity, and when we introduce the docetaxel 2 months after the CyberKnife, we have this kind of recall reaction, and you see the little spot of the different beam of the CyberKnife on the skin. And we had the grade 3 toxicity. It was a huge tumor of more or less 100 cubic centimeter. It's a big tumor, as you can see here. And you see the grade 3 toxicity here. And what we think that happened is just after the first chemotherapy on the CyberKnife, the tumor just starts to shrink. And so the skin in regard of the tumor is going inside the isodose, and so we get this toxicity. As you can see, we can see a little depression of the skin in regard of the tumor. So maybe at this level of dose, we need to do a CT scan before each session. There is only 3 sessions for the CyberKnife. What are the instrumental results? For the chronometer, we have no significant difference between the 2 breasts. For the ultrasound scan, we have a significant difference, but this significance is for whole breast, not only in regard of the tumor, and it's 0.2 millimeter difference, and there is no significant difference with the dermoscopy examination. What are the response? Remember, it's a phase 1. We have 3 different surgeons. There is no surgical difficulty, no complication, and we get 36 complete clinical response, 15 partial response, 1 stable disease. Breast conserving surgery is for 92% of the patient. We get 36 lumpectomy, 40% of quadrantectomy, 16% of partial mastectomy, or only 2 radical mastectomy. No secondary cutaneous healing problem, and most important is the pathologic response. All the pathologic complete response were found in the patient with the clinical complete response. So we had, again, 36 pathologic complete response. The pathologic complete response reached 67% at level 3, 43 at level 4, and 33 at level 5. We have no pathologic complete response at level 1 and 2. So what we think is we will use the level 3 as we have no toxicity at this level and we have a good pathologic complete response rate. Our follow-up, 36 months now. For the conventional radiotherapy, no toxicity was reported. 2 patients developed distant metastasis, 1 from the bone and 1 pulmonary and cerebral progressive disease. For the toxicity, we think that the 1 grade 3 toxicity is limiting at dose level not 4 but 5. 2 grade 2 toxicity, 1 recall reaction, no clinical sign of pulmonary toxicity, no cardiac toxicity, no other kind of toxicity, and we have 1 chemotherapy-induced toxicity, but with now no relationship with the SBRT. So the conclusion for us is that the SBRT for the breast treatment is well tolerated. We had complete histologic response since the level 3. So for us, it's a promising result in terms of pathologic complete response rate, but in breast conserving rate, study 2. It's a strong rationale for extending this study into a phase 2 trial, and we will use the dose of 8.5 gray on 3 fraction. So what will be the next study? We will start to randomize the conventional treatment, neoadjuvant treatment, 3 docetaxel, 3 FEC, then surgery, then radiotherapy on the boost. That will be randomized with 3 docetaxel on CyberKnife during the second cure of docetaxel, 3 FEC, surgery, and conventional radiotherapy without the boost. Primary objective was to evaluate the efficacy of radiochemotherapy on the rate of pathologic complete response. Secondary objective will be the clinical and radiological response, the conservative surgery, the toxicity related to the CyberKnife treatment, quality of life, disease-free survival, overall survival, and secondary surgery. And thank you for your attention.
Thanks, Professor Bondo, for this very kind presentation. Excellent results about the use of CyberKnife